I'm your host, Dale Sherbeck, and welcome to the HQ podcast. For those tuning in for the first time, the HQ is a podcast serial produced by CHA Learning and is your trusted source for important conversations on healthcare issues and topics from those that are leading and impacting the health system. Together, we'll explore these topics as we continue to learn together. CHA Learning is the professional development division of Healthcare Can and is uniquely Canada's only national fully online learning provider serving all of healthcare. So please check out more about our learning programs and services after this episode and discover how we collaborate with health leaders and organizations like those we feature on the HQ to empower healthcare professionals with the knowledge, skills, and relationships to impact health system improvement. Thank you, listeners, for joining me today for a very timely conversation about our health workforce. Over the past several years now, it has been no secret that we as a nation are facing a massive threat to our healthcare system vis-a-vis the capacity of our health workforce. Fundamentally, we are managing the impacts inherent in the gap between how many professionals we need to deliver the breadth and quality of health services we expect and how many people we actually have in our health workforce to do so. Conversations and strategies generally divide between a few buckets, including the health and wellness of our workforce, how to retain the workforce we have, how to better utilize the roles and people that make up our workforce, and how to increase the supply, both internationally and domestically. It is generally acknowledged that we can't recruit our way out of the issues we're facing, and so Health Canada and its chief nurse, Lee Chapman's Nursing Retention Toolkit released this time last year, was a very welcome addition to our shared work. However, getting the right supply is nevertheless a key pillar to a national health workforce strategy. But like the other pillars, this is also a complex issue with several important strategies, such as the role of our education system in developing new professionals. An education system that is itself a complex system involving many players, including but not limited to schools, professional associations and colleges, governments, regulators, and health employers. And that is the topic of today's timely conversation, during which we will dig into the report Health Canada released 2 months ago as an outcome of its Canadian Health Workforce Education, Training and Distribution Study. Dr. Geneviève Monod was appointed Health Canada's Chief Medical Workforce Advisor in August 2023 to support the federal response to current health workforce challenges. In this role, she led the study mandated by health ministers with the resulting report, Caring for Canadians, Canada's Future Health Workforce, approved in January 2025 at the Health Ministers' meeting. She has advised on Budget 2024 initiatives and engaged with the health workforce, health professions, education, regulation, and accreditation leaders across the country to support collaboration in addressing health workforce issues in Canada now and into the future. In January 2023, Dr. Monod also became Vice President of the World Federation for Medical Education, a position she continues to hold. Prior to her appointment at Health Canada, Dr. Monod completed a 10-year term as President and CEO of the Association of Faculties of Medicine of Canada on June 30th, 2023. She's a professor in the Department of Pediatrics and Emergency Medicine at the University of Ottawa and has privileges in pediatric emergency medicine at the Children's Hospital of Eastern Ontario. And I would be remiss if I didn't also add that personally, Geneviève is a proud mother of 3 and a grandmother of 6 and enjoys spending time with her family, staying active on her bike, windsurfing and skiing, as well as traveling to new locations to develop her skills in wildlife photography. So hi, Geneviève, and welcome to the HQ.
Thanks for having me, Dale.
So thank you again for joining us today. I know you're very busy with all the very important engagements you have in terms of sharing the information in the report that you've developed here. And admittedly, I did provide a very brief bio of your exemplary and long career, very impressive in terms of all your accomplishments. So perhaps if you're comfortable with it, we might begin the conversation with your journey and how it led to your role with Health Canada.
Well, thank you so much, Dale, for this opportunity. And I think you described my path in great detail. But really, the North Star for me in my professional life has been to improve the education of our health workforce, more specifically physicians for most
Hmm.
of my career, as I am a physician. And I've learned that improving that education not only relates to the curriculum, but it also relates to the environment in which we educate. And ultimately, if our goal is to support the health of our populations, we also have to be considering how many of our health workers we actually educate. And so that's where the aspect of the health workforce comes in. This is work that I got involved in when I was president and CEO of the Association of Faculties of Medicine, and am very pleased to have the opportunity to continue working in this area now as the Chief Medical Workforce Advisor for Health Canada.
Thanks, Genevieve. So you were appointed to this role in 2023, if I understand correctly, certainly in the middle of the pandemic. And Health Canada certainly was trying to take make an impression and to constructively help us through some of the challenges we were facing. So how did that become then the focus of the health workforce education training and distribution study itself?
So shortly after I was appointed, um, the meeting of the health ministers took place in October of 2023. And at that meeting, all health ministers agreed that it was important to actually undertake a study that would help them understand the current situation with regard to the education of the domestic health workforce, so
Hmm.
domestic supply, and help them appreciate what needed to be done to actually address the health workforce issues that we were being faced. Understanding that this is one element of a very complex situation with the health workforce, but that this specific issue had not been addressed, and really asked that this study be undertaken, which would be a first of its kind in Canada.
So fair to say we can't fix what we don't understand.
Exactly. So this was about really trying to understand not only the current landscape with regard to the education of the health workforce, comparing what's happening in education and training to the current um, demand for the health workforce. So, what is that gap? And then looking at the trends, the future trends, we were asked to look into 10 years, which is very challenging to do in this
Yeah.
space. But so that we could help inform the ministers, the provinces and territories as to what was potentially required in the future.
So easy work, tough work, I can imagine. But what was your perspective in terms of undertaking the study?
Well, first of all, it was a great opportunity, and really was thrilled that the ministers agreed that this work needed to be done because, as I said, this had never been undertaken in a pan Canadian landscape before. We had to make some decisions as to how we were going to do this because, of course, they wanted the report back within a year.
Mhm.
So, and of course, it took us a couple months to actually confirm, how we wanted to move forward. So we did have to decide which health professions we were going to be looking at. And we knew that the government's priority was primary care. And we knew that we had information on some health professions more than others. So, again, with High being one of our partners in this work, understanding the information that they had. And so what we landed on was, in fact, looking at 5 professions.
Mhm.
So that was, and parts of them. So first of all, for physicians, we were going to look at family physicians related to primary care. For nursing, it was to be the 4 registered nursing categories, including nurse practitioners.
Mhm.
Um, and then occupational therapy, physiotherapy, and pharmacy. And again, for all of these, we did have CI-HI data that we could use to be able to do the modeling and forecasting that was going to be required to answer the mandate of this study.
And just to clarify, when you talk about the nurses, are you talking about nurses in the whole system as a whole, or just in the primary care family side of the community care side of things?
Yeah, so great question. And these are some of the points we actually had to clarify. And I think it's important to say that this study, although was published by Health Canada, first of all, this was a federal, provincial, territorial led study. And
Right.
so the work was done within the Federal Provincial Territorial Committee on Health Workforce. So this is at the level of the ADMs, and we had a project team with some of those members that also included CI-HI, that also included Health Workforce Canada. And we really needed to make sure that we engaged with all the experts in these fields. So we had experts that were very knowledgeable about their own profession. And so the national groups, whether they were the education groups or the national associations, as well as the experts in health workforce. And so we have many experts in Canada,
Hmm.
and again, other experts specifically related to some of the professions themselves. And so, with the advice of everyone that we could think of to bring in to our conversations, we really worked at trying to find, the best approach and to make, I'm going to say, the least bad assumptions as we undertook this work. And so, one of those questions was, do we actually look at, for example, for family physicians or nurses, only the work they do in primary care, or do we look at all of their work? And we decided that we were going to use the parameters around all of their work.
Okay.
So, in fact, the choice of profession was the link to primary care, but otherwise, we were looking at all of the work undertaken by those professions.
Perfect. Thank you. So I think you're sort of we're talking around, I guess, the question about data. I mean, I know in terms of the work that we ourselves lead through Healthcare Can and our advisors and members, um, and certainly through the pandemic, the issue about data and access to data, and became a bugbear for almost everybody, and continues to be, I think, as we're trying to pull ourselves forward into the next chapter. How did you, address some of those data challenges?
Yeah, thank you. And I think, there are many layers to the data challenges, and perhaps I'll just highlight a few. But I think, first of all, and it's important for me to mention off the bat, is that the other important piece of our mandate was to pay special attention to the issues that relate to the care of people in rural and remote communities, as well as to specifically address the Indigenous health workforce. And we felt it important that that last piece on the Indigenous health workforce was actually led by Courtney Clark, who is an Indigenous scholar and has her own chapter in our large report, and really provides some important considerations with regard to the Indigenous health workforce. And so when you come to the data aspect, again, we need to be cognizant of the importance of the sovereignty of Indigenous data. And so that was one first aspect that we needed to consider. The other question around data is, one of the important um, data collections that we required was to actually be able to understand what was currently taking place in the education of these professions. And so for some of the professions, there actually exists a national organization that already collects this data, and for which we just had to knock on their door and invite them to work with us,
Yep.
and that was great. For others, they had their members who had their data that we then had to have collected on behalf of the study, and again work collaboratively with their members. For others, it was much more complicated because, and I'll just give the example of nursing. There is no association or grouping in nursing that actually has um, uh, as their members all of the institutions that provide nursing education. And the reason for that is that nursing education may happen at a university, it may happen in a college or a community college, may happen in a CEGEP, and it is much more complex across the country. And again, right, and there are hundreds of these of such um, institutions that provide nursing education, whereas for the others, we're talking, just a couple dozen. And so there, for the nursing data, we actually had to work collaboratively with our ministries of health across the province to ask them to get data from their ministries of education if they didn't already have the data. And so that was an interesting realization that in fact that data was actually much more difficult to obtain, and depending on the jurisdiction and the source, we were not able to get all of the different elements of data that we were hoping to obtain. And so you'll see that in the report at several locations where we say, we tried to get this data, we couldn't. So that's just the education piece. And then for the health workforce piece, as you know, we worked with CIHI, and there again, we were only able to work with the professions where CIHI had what we call row level data, where they have information that's much more specific. And even there, the CIHI data does the best that it can based on what has been provided by their sources. And so just some examples of the challenges with regard to just obtaining the data itself.
Yes. So, in some ways, I guess it's a bit of a microcosm, I guess, of some of the challenges of the health system as a whole. But so, thank you for sharing that and for working through those. So, I mean, the report is a big report. So for those that haven't looked at it, it's comprehensive, I think is one way to say. So we don't have time to do an audiobook of it here, as much as that would be fun. And you do have some very well laid out, I think, recommendations that come at the end of it that distill all the results of the study itself. So maybe just to summarize maybe some of your key takeaways from that, Geneviève, that we can share with our listeners, so at least situate some of the conversation we're having here today.
So Dale, with regard to our findings, let me start with the focus on the significant underrepresentation of Indigenous people in our health workforce.
Mm-hmm.
This is not a surprising finding, but again, it was clearly identified. And here we know that, not only is that an issue, but that we also need to be looking at the importance of the curriculum as relates to Indigenous health perspectives. And we need to ensure that the experience that Indigenous people have in trying to access education in health professions is significantly enhanced. And so, those are some of several of the highlights that we were able to bring forth in our report. The next piece, which is, what a lot of folks are interested in, are the numbers. And what is important is that we remind you that we were dealing with data that was not as pristine or precise as we had wished. And so it's not so much to look at the numbers as a precise number, but it gives
Hmm.
you an idea of the scale. And when you look at our projections out to 10 years, again, it really just gives you an idea of the trend.
Yep.
And I'll just give two examples of the numbers because they are the ones that have raised most attention.
Sure.
So for registered nurses in Canada right now, we've got around 270,000 registered nurses practicing. That's the supply. And we have estimated that the current gap, what we're missing is 27,000. So it's basically 10%, right? So we need 10% more registered nurses across the country. And yet, every year in Canada, there are only 9,000 graduates, right? So in order to catch up, right, we need to actually be thinking very seriously about how we train more nurses. And again, just with regard to nurses, you very kindly brought up the great work done by Lee Chapman, our chief nursing officer, on the retention toolkit, because that's obviously a very significant factor for nursing as well.
Yeah.
And let me give you the numbers for family physicians, which are really quite dramatic. In Canada, currently, we have 46,000 practicing family physicians. And we estimate in this study that our, our deficit, our gap currently is nearly 23,000. So we're saying that we need around 50% more family doctors right now. Every year in Canada, we graduate 1,400 approximately. So that's an enormous, enormous gap. That I think is probably the most dramatic number from our study.
And that doesn't even take into consideration then, right, that we were at a bubble in terms of our demographics, right, with the people retiring at record numbers.
So what we've tried to do uh, in both our modeling and forecasting is based on, again, the best estimates, based on all the information that is known around population, around the demographics of physicians, around how physicians are working now. We've brought in all those factors. The other factor that was brought in is everything that our current ministries of health across the country could tell us about expansions, right? So some of them have made the
Hmm.
news, but anything that they could confirm to us about expansions are included there. So when we say, well, this school is increasing in size, there's a new medical school coming, that's already in this equation. So we continue to then have a significant challenge in number of physicians and family physicians. And when you look at the 10-year forecast, uh, we're saying, so for registered nurses, it was 27,000. If nothing changes, because that's the thing about the forecast, is that it's about if nothing changes. And we know that's not true. We know things will change, but if nothing changes, our gap, our deficit in 10 years from now will be 30,000. Okay, so we will be in worse shape. For family physicians, we're saying nearly 23,000 now. That will increase to 27,000 in 10 years from now if nothing happens. So those two lines are going up, they're going the wrong way. And so that is some of the important numbers that came out of the study. Um, so I think I'll stop there.
It's hard not to be alarmist then, I think, when you publish that or read that. I, in, and yes, maybe I'll leave it there too. Um, but yes, it is. Those are shocking numbers. So I mean, so we have a shocking problem. We have a problem that's not looking to get better anytime soon. Um, what did you recommend? I mean, coming out of that, and you know, and how did you come to the recommendations ultimately that you did?
Well, thank you, Dale. The I can summarize the recommendations in about 6 points, but yes, there are there's over 20 recommendations in the report. Um, and again, I will start with the fact that related to our Indigenous health workforce, the solutions need to be Indigenous led
Hmm.
and need to be supported in a good way. And that requires, that's a significant body of work in and of itself.
Yep.
The I think most um, important recommendation that engages our governments relates to not only the need to increase seats because that is self-evident, but it's the need to actually increase the opportunities for collaboration between ministries of health and ministries of higher education or whatever their ministry is called in each jurisdiction. Because if we don't enable planning together, we won't be able to address the healthcare needs of the populations. And so, there are some sectors where that in some jurisdictions where that is happening to a certain degree, but it certainly isn't present across the country.
Hmm.
We cannot do this work without better data. And when we talk about data related to the study, this is data that starts with the journey of a potential um, healthcare professional. And so this is, we need data about who's applying to the health professions, who's getting in, uh, where are they from, um, how is their educational journey undertaken? What are any issues during their educational journey? How can we follow this individual throughout not only their educational journey, but then when they join the health workforce? This is something that happens with physicians. They have a medical identification number that stays with them throughout their career, but we don't have that for other professions. And so it's very difficult to actually measure where people started and where they end up if you're trying to address issues such as those in the rural and remote communities. How do you do that if you can't tell where somebody came from?
Yeah.
And so that data needs to also be more robust as it relates to the health workforce itself. And so that's where it's important to be able to know where the health workforce is right now, who they're working for, how much they're working, so that we can actually understand, the robustness of the workforce. We need to have better opportunities for modeling and forecasting and doing that collaboratively. Again, at the end of the day, the decisions around education and workforce belong to every jurisdiction, every province, and every territory. But certainly there are many opportunities to work collaboratively to understand what are potential best practices in modeling and forecasting, and how can jurisdictions bring that back and have those conversations between their ministries of health and ministries of education to plan better. We talked about the seats, so that's essential, and then all of the resourcing and capacity that's required around the seats. And then finally, our recommendation is that we really need to engage with all of the stakeholders um, in the health ecosystem in order to be successful.
So a lot of, yeah. And a lot of challenges, a lot of recommendations. Your recommendations, I think, probably for obvious reasons, given your role and that of Health Canada's role, right, stop short of saying, I mean, you say what needs to happen to some degree, but not necessarily who should do it or how it should be done. It would be fair.
Um, I think it's in there, but there's not. This is not a an implementation report, right?
Yeah.
That will come, but I think it does identify that this has to be a systems approach, right? We really have to um, get everyone engaged, and everyone has um, has a role. And if we don't do it all together, we won't succeed.
Yeah, which has been, I guess, the Canadian tradition to date. So, of working independently in our own different jurisdictions and silos, part of, I guess, what has perpetuates the challenges that we see, which sort of leads me to, the question around, some of your challenges and barriers as you identify. So, you certainly, I think, not a surprise, right? Talking about we need more seats, and you're saying organizations and jurisdictions are developing more schools to sort of to advance that and solve that. And then on the other side of that, we know, and I know just through our own work through CHA Learning, that the you know generating more learners means putting more pressure on employers to support those people, right? So every seat needs, certainly in most of the professions, has a practicum or a placement or a residence or some kind of version of that, where they need to practice in place. And employers are saying, well, that takes away time from the bedside or from delivering the core services that we have. So we don't have time to support learners. We need more learners, but we don't have time to support them. So, I mean, how do you deal with that juxtaposition that it seems like this never-ending sort of, you need to do more of this and I need to do more of that, and we can't get along or get work together in this space?
So I think the first step is that we all need to agree that we all have a role and that this has to be priority, despite being in a system that is still recovering from COVID,
Hmm.
and that you know we also need to appreciate that these issues have been there for a long time, right? For physicians, Canada is 33rd out of 36 OECD countries in how many physicians we graduate every year. This didn't just happen in the last couple of years. This has been like that for many, many, many years. And what COVID has done, it has helped us appreciate just how precarious our health workforce was coming into COVID. And then with COVID, we were dealt with a situation that we could no longer ignore. Um, and so if we agree that this is a top priority, no matter what else, and if we don't fix this, we're never going to get out of this. So that's the first, that's the first important common goal. And we all have our roles. So we've talked about governments at the end of the day are the ones who need to fund the seats, create the seats, decide which seats, are going to be created in their jurisdictions. We have the educators that obviously are the ones who need to help find those resources to actually provide the education. We have the regulators who may or may not be putting cogs in the wheels of trying to enable that education. We have the accreditors, same thing, who may have some stipulations that make it so difficult to bring on more learners because of the requirements for the length of practicums, for example. We've heard that in some of the professions. Certification bodies as well,
Hmm.
our professional associations. So we need to ensure that our professional associations, who obviously are advocating for their members, whether they be physicians, nurses, et cetera, to say, look, we know you're tired. We know you are dealing with a system that is challenging, but we need you to help support the education of these learners, because if we don't do that, um, we will not be able to, to see improvement moving forward, right? We really do need to have those who are going to come after us to provide the care. And so, whether you're someone who's working in a smaller community and where that touches you directly because you're going to be needing to be replaced one day, or whether you are working in a large institution in a hospital, you know, every individual clinician needs to appreciate that they are needed
Yeah.
in some manner to help educate. And as clinicians, we've all been part of a system where we have benefited greatly from our teachers. And as self-regulated professions, we really do owe it to our profession, to those who are coming up in our profession, to actually give back. And so I think that hasn't been the case up until now. The teacher has been sort of a
Yeah.
very specific group, but now we need to really open that up and really enable most clinicians to actually have learners with them. And so that's a significant culture shift, I think, for our professions. And the other important piece, and we see this when we look at the innovations that were highlighted in our report, is that we need to be engaging with our communities more. And communities have a really key role in either helping us create innovations in the way we educate, but also in encouraging an environment where that education can take place. So we know that, for example, for rural and remote communities, if they can establish some teaching units, or even have preceptors willing to and clinicians willing to have learners in their practices, there's a much higher likelihood for those individuals to actually want to practice, those learners to want to practice in those rural and remote communities in the future.
So, I mean, there's a lot of questions I want to ask in this. I know. So, I mean, certainly you're leading into the other question, which is like, so what are the innovations and advancements that are happening in this space that perhaps provide hope in all of this? Um, but I do wonder, um, like in some of the challenges that you're facing here, is that, and and I appreciate it's a difficult thing to talk about because nobody perhaps really wants to have that conversation. But what is the economic cost of this, right? Um, uh, because I guess like one of those, like all of this costs money, both in terms of the development of these health professions. Right, our publicly funded health, our education system is subsidized through our tax dollars on the one hand, and then there's the dollars invested in the healthcare system and developing these people and helping them to grow and mentor and develop in that space, not to mention just hiring them. So does that factor into some of the study, or into perhaps some of the future conversations that may be had?
Yeah, thank you, Dale. And this actually is a point that was brought up by the ministers. This was not an economic study at all,
Hmm.
and yes, there is a cost, but I would also suggest, just at the highest level, there's a greater cost of not doing it, and
Hmm.
and the cost is would be borne by our patients who would not be getting the care that they need. And at the end of the day, when you look at it globally, um, we are a well-resourced country, and we should be able to train the healthcare workforce that our population needs. And so, with that in mind, I think that's where some of the innovations do come in, and maybe I can take a moment to
Sure.
just highlight a few of those. And it was just brilliant to be able to learn about these innovations across the country. So, just to bring three to your attention, um, in Moose Factory, in the Winnebago region, Queen's University has actually set up is setting up a training program that will include, in the first couple of years, uh, students who are aiming uh, for MD, for registered nursing, for occupational therapy, physiotherapy, and emergency services. And so they're being trained together in the first couple of years. And so, for some of those professions,
Hmm.
they can slip off after a couple of years and start practicing. The MDs, of course, would need to continue their education longer. But this is a model that exists in other countries already, and so bringing those type of models into an education setting in Canada is fantastic. And we know that, by training in an interprofessional manner, individuals are more likely to be very comfortable in providing care in an interprofessional manner. And so that is, one example. Another is in Yukon. They have a learn where you live program. So individuals who are working in that area can receive distance learning to undergo a program in nursing, and that is supported by New Brunswick. So again, a really nice example of jurisdictional support there. And the last one I'll highlight is in northern British Columbia, where they, for many years now, have a very well-functioning Northern and Rural Pathways program. This is part of UBC, but it all takes place in the north, and they have an incredible track record of retention of learners who get established in the north and never want to leave. And so again, it can be done. The thread in all of these is that the communities were very involved in the establishment of these programs and continue to be supporting the programs and the learners throughout. So,
Hmm.
just to give you some examples.
Those are great examples, and I think, well, whether by design or not, I mean, the thread is that they're all smaller communities that you've described, that are communities that we might otherwise, I think, describe in the challenges being faced as those that are under most duress in terms of recruitment and retention. And yet they're also, I mean, I guess, the adage about, necessity being the motherhood of invention. They're the ones that are innovating, as you've described in this space. Do you see that in terms of more of the examples that you've seen, or?
I think, there are many examples as well of being able to accelerate education. And, I'll use medicine as an example. In some medical schools, MD education is 4 years, in some it's 3 years.
Hmm.
So, are there opportunities there to actually try to streamline that a little bit better? And, I think our ability to innovate is there. Innovation in itself, again, is something that takes time and energy and resource, and is essential to to be part of the solution. But again, the implementation of any innovation at the end of the day is up to every jurisdiction.
Yeah, for sure. So you've mentioned, some of the feedback, I guess, from the First Minister. So you did present it to them in January before the public release of this. And if I understand correctly, I mean, they were obviously very supportive of it so that it could go public. But can you share anything more in terms of the efforts, I guess, following the First Minister's meeting, or not the First Minister's, the Health Minister's meeting in January?
Yes, so the other important approval is that they requested that we establish a work plan that the deputy ministers establish a work plan based on the recommendations. So that is currently underway again, engaged in that work with the Committee on Health Workforce as a starting point, and that work is underway. Of course, we are currently in an interesting time, and how this will all end up. We will find out in several months as we bring a potential work plan to the deputies and then deputies to the ministers in the next several months. But that work is currently underway.
Okay. Um, yeah, we live in interesting times and a time of change for sure. That certainly has impact on some of, I think, what you're describing. I'm curious as well, Genevieve, because I mean, obviously, so much of what's been focused on here, in terms of your study and in terms of the recommendations, is on the domestic supply itself. Um, were there, I guess, was there data or conversations in terms of how the move throughout the health system at the same time in parallel to this, looking for short-term wins and opportunities to help balance our gap or mitigate some of the challenges, the emphasis on recruiting internationally educated health professionals, physicians and nurses and others. Um, so how does that complement or flow into some of this work, or can you comment on that?
Yeah, absolutely. And Dale, as you know, the federal, provincial, territorial governments, have been working hard over the last many months to try to address, the issues and the barriers that exist for internationally educated health professionals. And that work continues. I say this report was specifically around
Yeah.
domestic, but that work continues, whether it's related to um, the ability to obtain a license for internationally educated individuals, whether it is, access to all of the different elements that are required to be eligible to be assessed. So that work, continues to be in play. I
Hmm.
would also say that another piece that was actually approved at the same ministers' meeting is Canada's ethical recruitment framework, which is based on the framework from the World Health Organization. So that's been sort of updated and Canadianized, and that document was also approved and will be made public in the near future. But I think that's another important piece. Internationally educated workers will always be part of our workforce,
Yeah.
and we need to, when we are bringing in internationally educated individuals, we need to do so in an ethical manner. We need to, reduce unnecessary roadblocks or barriers. And at the end of the day, we want to make sure that those individuals are able to provide safe and competent care. And so, with all that in mind, that work does continue, and there will always be a place for internationally educated workers in Canada.
And I guess, but without, I guess, taking a policy position on it specifically, you're not also going to say that the 27,000 nurses or the 23,000 family physicians is going to be bridged through international recruitment alone. That I think part of, I mean, that we need to invest in our domestic supply effectively.
I think at the end of the day, the ideal is that we not be dependent on supply of health workforce outside of Canada. We should be self-sufficient, but always welcoming of internationally educated uh, healthcare providers.
Yeah, and a strong parallel, I guess, to the conversations we're having with respect to Trump and tariffs. So, looking internally in terms of our internal capacity. So, um, So obviously, you had, as you talked about at the outset, in terms of some of your challenges and having to, constrain the scope of the work that you're doing to make it manageable and something that you could effectively do in the time that you were given. So focusing on the 5%, five professions that were included. Are there further plans to look outside of those professions, as at the sort of the broader workforce and some of the other either hard to recruit professions or others that are certainly presenting challenges in terms of our health systems.
So certainly, as part of our recommendations, we do suggest that more study is required, and that it would be relevant to actually look at other professions, and again, based on what may be related to the professions that seem to be the greatest challenge for our system currently. We also talked about the need to look at other groups that historically have been marginalized. This time, we focused on Indigenous health workforce, but obviously there are many other groups that should be looked at. And so again, that would be potentially part of the work plan that is yet to be confirmed, but that certainly those recommendations are there to undergo further study.
Perfect. So I know that you probably can't sort of look into that crystal ball too far into the future right now, but do you have other things that does lie ahead for you in your office in terms of that which you do know?
So currently, we really are focusing on the dissemination of this report, engagement such as events like we're undertaking today, and establishing that work plan and arriving at a work plan that is really going to help address those recommendations.
Great. So, any other final words that I can give to you, Geneviève, to bring this great conversation, very interesting, and so much more I could ask you, but to a close?
Well, thank you very much, Dale. I think the last piece I would just highlight an understanding that many of the members of the audience are related to the employer sector
Yeah.
of our whole ecosystem, and I think that. The employers truly have a crucial role here. Not only are they often those who will be welcoming new grads in whichever profession, and so the way that new grads are welcomed, the way that new grads are supported in the employment environment. Um, so that whole workplace piece, um, that culture shift of saying, yes, we are busy, yes, we have lots of patients, yes, we are understaffed, and we need to take on learners, and we need to be teaching, and we need to continue to enhance our workforce. That's a huge piece, a very important piece. And I think the final one would be the data collection. And so
Hmm.
um, we need data from all of it. And so how employers can be part of that data solution, I think, is another important question. And Dale, I hope to have the opportunity to speak with you and your colleagues many times in the future to try to address those specific questions.
Yeah, thank you. I know our members are keenly interested in speaking with you as well, and working on what are the solutions that we can collaborate on together across this country, because everybody does, I think, deeply care about these investments and the impact that it's going to make on both our current workforce and the Canadians that we're here to serve. So thank you for sharing your time with us here today, and your offer to continue to engage with us on the future.
My pleasure. Thank you, Dale.
You've been listening to the HQ, and I'm Dale Sherback, your host. You can find this and other future episodes on the CHA Learning website, Apple Podcast, or Spotify. We'd love to hear what you think, so please follow us on our other social media channels. Thanks for joining us in this discussion today. Please join us next time.